السلام عليكم. محاضرتنا لهذا اليوم راح تكون على الفاسكولار تروما. أنا وياكم دكتور ياسر عامر عيسى. Now to start the lecture we have this case scenario of 32 years man who sustained a gunshot wound in his left thigh. He got profuse bleeding from the site of the wound. The vitals are as the follow. Blood pressure is 90/40, the heart rate is 134 beat per minute, and the respiratory rate is 20. On arrival to the emergency unit, he was having cold extremities and shivering. Now, from what we have said and from the vital signs, what is the most probable diagnosis and how could we manage this man? This man, as the history said from the case scenario, he is a victim of penetrating bullet injury to the thigh with profuse bleeding. From the vital signs, he seems to be in a shock state, low blood pressure and high heart rate. The respiratory rate seems to be normal. The examination called extremities and shivering. This indicates shock state also. Now, the most probable diagnosis we will see and how we manage this man, we will see in the coming slides. Now, vascular trauma can result either from blunt or penetrating injuries. The pattern of the injury differs according to the mechanism of the injury. It means the injury that is associated with blunt trauma is more severe than injuries that are associated with penetrating type of injury. Blunt vascular trauma is usually associated with increased amputation rate. Why? Because in the blunt trauma, it will result in tissue damage more than penetrating type of injury, and the results from blunt injury it being associated with significant fracture and tissue loss. So there will be maceration of the tissue and bone fracture. The other cause is that diagnosis of blunt trauma is often delayed because the patient who presented with injury due to penetrating type of trauma, he will present with profuse bleeding and obvious bleeding, whereas patients who suffer from blunt trauma usually they don't have a bleeding, and that's why their diagnosis might be delayed, so they might be presented with delay vascular injury. Now, the vascular injuries that can be subdivided or classified into either contusion, puncture, laceration, or transection. This classification depends on the trauma that happens within the vessel itself. We will see pictures in the coming slides of such type of vascular injury. As we can see here, contusion, it will associate with thrombosis and the 6P's, the signs of ischemia. Now, in contusion, we will see here that there will be maceration or there will be laceration within the vessel wall, not like that happens in partial transection or laceration or bleeding. So, contusion, it is usually associated with the blunt trauma, so we don't have obvious bleeding, but it might be delayed due to intimal injury. Whereas in laceration or in partial transection, here we can see obvious bleeding, so it can be presented in an early stages. Sometimes partial laceration, it will lead to pseudoaneurysms with expanding hematoma, as we can see here in the diagram or in the picture on the right side, that this small puncture in the vessel wall, it will lead to bleeding and hematoma. Such hematoma, it might form just like a false aneurysm or just like a wall within the vessel, but usually it's expanded. And whenever we have an expanding hematoma, we will see what signs that may urge us to shift the patient to the emergency room or to keep him under observation, the hard sign or the soft sign. Okay, now a complete transection. Usually the patient who presented with profuse bleeding, after a while the bleeding will be stopped. It means that the patient, the type of the vascular injury in such patient is a transection, complete transection. As we can see here, it's a kind of defensive mechanism. When we have a complete transection, there will be a retraction of the adventitia or the external layer of the blood vessel to stop the bleeding, just a kind of protective mechanism. So the bleeding might stop. We don't have to be happy whenever we have bleeding at the site of the injury, and witnesses, they said no, the bleeding stops later. It means that we might have a complete transection. Sometimes a tangential injury in the blood vessels, it might cause a tract between the artery and the vein, forming an arteriovenous fistula. What I'm saying, that we have to be having a high index of suspicion whenever we have a vascular injury at the cause of the major vessel, penetrating type of the injury, or even a blunt, having a distal pulse, positive distal pulse at time at start doesn't mean that we don't have a vascular injury. So we have to be having a high index of suspicion, complete transection. It might presented without obvious bleeding. Arteriovenous fistula, it might not presented with obvious vascular bleeding or external bleeding. And even a distal pulse, positive distal pulse, it might present with vascular injury. So we have to have again high index of suspicion. We have to send the patient for more investigating tools to confirm that we have a vascular injury. Now, how the patient will present to the emergency unit or to the after he has been a victim of vascular injury. The clinical features usually it depends on the clinical feature depends on the site, the mechanism, and extent of the injury. So when we have an injury in the limbs, it's not just like the same that injuries, vascular injuries in the chest or in the abdomen, and even the mechanism of the injury, whether it's blunt, as we said, it might be presented in a delayed manner, not just like the penetrating type of injury. Now, signs, clinically, we can divide it into hard and soft signs. The hard signs, it means that my patient have to be transferred directly to the emergency room. I don't have to wait for this patient. What are the hard signs? The hard signs are absent pulses, therefore pulses. On examination, the presence of bruit or palpable thrill, active hemorrhage or active bleeding, expanding hematoma, distal ischemia. All these are hard signs, and the hard sign, again, it means that I have to rush my patient to the emergency unit to not to delay operating this patient. Now, what about the soft sign? Soft sign, it means that I can wait for my patient. I don't have to be in a rush. I don't have to be in a hurry and transferring the patient to the operating theater. No, I can wait for him. I can manage him well. I can state him, waiting for such more investigating tools. Such signs are hematoma, not expanding hematoma, history of hemorrhage at the scene of accident. As we said before, that the witness, they might say that the patient, he developed hemorrhage at the scene of the accident and the blood stopped. So it might be a sign, or it might be a cause for arteriovenous fistula or unexplained hypotension. I don't have external bleeding, I don't have a source of bleeding, but despite resuscitation, I have unexplained hypotension. Such hypotension, it means that I might have a vascular injury and I have to search for it. Or the presence of peripheral nerve deficit, it might be also a sign, or a soft sign, and a sign of vascular injury. Now, we said that the signs of limb ischemia, acute limb ischemia, the 6Ps, pain, when we have cold extremities, pallor, when we have paresthesia, we have pulselessness, undetected pulses, or when we have paralysis and movement or non-moving limb. These signs, they are the 6 P's, and whenever I have one of these signs, I have to have a high index of suspicion of vascular injury. Now, what are the investigating tools that I have to do for a patient with a vascular injury? Now, hard signs, they often require urgent surgical exploration without prior investigation, but definitely I have to do general investigation, just like the complete blood picture, hemoglobin level, and blood group. Then I have to shift my patient or transfer the patient to the surgical or to the operating room. Arteriography or angiography, I can do such investigating tools to confirm the extent of the injury in a stable patient, but equivocal signs and symptoms. The signs, they are not straightforward for a vascular injury, and still I have a suspicion, so I can send my patient but to arteriography or to angiography, but he should be in a stable condition. And the second consideration is to exclude injury in a patient without heart sign, but I have a strong suspicion or high index of suspicion of a vascular injury. The role of double ultrasound and vascular trauma remains to be defined. Usually, it's the first investigating tools, the non-invasive investigating tools, and whenever I have an equivocal decision about vascular injury, I can shift to arteriography to confirm the vascular injury. Now, what are the management, or what are the lines of the management or the treatment of a patient with a vascular injury? Usually, it requires a multidisciplinary approach because vascular injury, in a limited cases, they are presented with a pure vascular injury. They might be associated with a fracture, with tissue loss. That's why I have to have a teamwork of orthopedician and the plastic surgeons. Now, whenever I have decided that my patient have to be underwent a surgery, what is the aim of the surgery? The aim of the surgery, number one, is to control the life-threatening hemorrhage. So I have to control the bleeding. Without controlling such hemorrhage, I might lose my patient. And second is to prevent the limb ischemia and to salvage or to save the limb from amputation or from being lost. Now, if the surgery is delayed more than 6 hours, revascularization is unlikely to be successful. The use of arterial shunt controversial. I can use arterial shunt, or sometimes preferably I use the vascular or the venous shunt as a shunt, and it may reduce ischemic time and allow early fixation of the fracture. This is for the arterial shunt. Sometimes when we have a fracture, the aim of the vascular surgeon is to control the bleeding, number one, and the orthopedic, they have to do the fixation of the bone. Then I revascularize, or either I will anastomose the lost segment, because sometimes during fixation they might injure my repaired artery. So that's why I have to control the bleeding, number one, and then after they finish the fixation, I will revascularize, or I will anastomose. During that period, I might use shunt, arterial shunt, to secure the blood, or the source of of bleeding, or the source of the blood, to the distal segment. In this slide, we can see what are the options available for the vascular repair. Either I can use simple suturing of a puncture hole or lateral wall laceration in a vessel, in an injured vessel, or I can use vein patch angioplasty, we will see in the coming picture, resection and end-to-end anastomosis. This is the usual repair, vascular option repair. Or when I have a large defect and I cannot approximate the two vessel ends, the proximal and the distal end, I might use interposition graft. I can use either the contralateral saphenous vein, which is the ideal interposition graft, or I might use a prosthetic graft material if I have poor vein or bilateral limb trauma. In this slide, we can see a total cut of the femoral artery. and I've been anastomosing end-to-end anastomosis of this vessel. And on the right side, this is the final result of total cut femoral artery. This slide showing on the left side a total cut also of a vessel, but here, as you see, there is a long distance of vascular loss or a vessel loss. So I cannot approximate the two ends because due to the vessel loss. So I'm using interpositional graft, and usually I'm using vein, the saphenous vein. For the saphenous vein, we have to be oriented about whenever I use the vein, I have to make it upside down to because if I use it at the same side without changing the orientation of the vein, the presence of the valve, it might impede the blood flow. So I have to make it upside down so that I can use it as an interpositional graft. For this slide, I've been used the vein as a patch angioplasty. Here we have a defect on the anterior aspect of the vessel. I can use or I can repair this vessel by resection and end-to-end anastomosis, but usually I use a vein as a patch to secure the defect in the anterior aspect of the vessel wall. One of the complications of vascular injury is a false aneurysm. Commonly, it follows catheterization of femoral artery in diagnostic or therapeutic procedures for the coronary arteries. Usually, the access is from the femoral artery. Sometimes, false procedures, it might lead to false aneurysm, in which there will be an injury in the wall of the femoral artery or the access site. Now, usually, the patient will present with pain, bruising, and a pulsatile swelling. I can confirm my diagnosis by double ultrasound or even by angiography, arteriography. It might respond to ultrasound-guided compression therapy. The therapy, one of the modalities of the therapy that I can occlude this aneurysm, this false aneurysm, by compression, ultrasounded compression, or I might use I might go to surgery, suturing the defect, and usually it will be by, as I said before, by lateral repair of the hole. Sometimes I can use vein patch if the defect is big enough. This slide shows how I might end with false aneurysm. This is usually the access site, the femoral artery. Sometimes multiple puncturing of the femoral artery in a blunt, usually as it performed under blunt procedure without Doppler guided, I might result or I might end with false aneurysm and its complications. What are the complications of a false aneurysm? False aneurysm, if it's left without being treated, I might end either with infection of the aneurysm, or I might end with rupture. So the treatment is by, as I said, either ultrasounded compression, guided compression, or the surgery for repairing the puncture, or I use vein patch angioplasty. Now, the second complication of vascular injury is arteriovenous fistula. Often it presents several weeks after the injury. The usual history that the patient, he developed bleeding at the site of the injury or at the scene of the injury, after which the bleeding will stop. The patient will present to the emergency room with a distal pulse being positive. So I will be happy and I exclude the vascular injury if I don't have a high index of suspicion. I will discharge the patient home. He will present several weeks with complaining of swollen limb with dilated superficial veins, and on examination I might see bruit that presents throughout the cardiac cycle. I can reach the diagnosis, I can confirm my diagnosis by angiography. Usually, I will reveal a fistula that can be present between the arterial and the venous system. Treatment usually is by surgery. The fistula will be divided, both the vein and the artery will be sutured, and to prevent recurrence of this fistula, I might use a facial flap to be interposed between the artery and the vein to reduce the risk of recurrence. Now this picture where the arrow is showing an arterial venous fistula between the artery, the femoral artery and the femoral vein. This is before the repair. After repair, I will excise the fistula, repair the arterial and the venous side, and put a flap to prevent its recurrence. Now back to our case scenario. Our man, he suffered from a vascular injury. Usually, from the history, he is suffering from injury to the femoral artery, and he presented with shock. So my lines of management is to start with A, B, C, D, E, securing the airway, breathing, and the vascular access. I have to put two wide bore IV access. I have to resuscitate my patient, withdraw blood for cross matching, and resuscitate the patient. And despite and I will follow my patient by examination, by the presence of the hard sign and the soft sign. If I have hard signs, then I have to rush my patient to the operating theater. If I have vital signs, no, I can wait for my patient. I can keep him under observation, do further investigating tools to exclude vascular injury. And whenever I have a vascular injury with a hard sign, then as I said, rush him to the operating theater, and I can do vascular repair from the previous vascular repair options. Thank you for listening and joining us in this lecture. If you have any question, please don't hesitate to ask me for any type of question regarding the vascular injury. Thank you.